Okay, Monotosda, you are there?
Yes, I am here.
Fine. Let him start the session. We have the discussion at the end after both the speakers finish off their deliberation. Prakash, you please start.
Good evening to all. So it is a proud privilege to welcome, and I'm thankful to the Santanu who organized the meeting, a very important subject also. So therefore controversy is there and debate is there whether proximal LED to be treated by intervention or by CABG. And first thing favor for the PCI, and I'm requesting Dr. Hazra and head of the department, AMRI Hospital, he talk on the subject in support for the PCI in favor for management of the proximal division. Dr. Hazra, please.
Right, thank you. So thank you, Dr. Guha, Dr. Panja, and the rest of the panelists. My patient is 50 years, female, diabetic, hypertensive, hypothyroid, hyperlipidemic, has angina for last 3 months, ejection fraction around 45%, past history of anterior MI 3 years back, GFR 45, insomniac, depressed, executive in MNC with strong family history of sudden cardiac death. And she has read about ischemia trial and had undergone CT angiogram, which showed a proximal LED lesions with CT-FFR of 0.78 and heavy calcium and 25% ischemia on MPI. So these are the long list of medicine, and it is straight. Can you hear me?
Yeah.
Yes.
Okay. So it is. She is stable now. Now she is actually moving towards a path of immortality, and she has taken help of medicine. And I told her, look, you can go into the path of immortality, but you have to take all these medicines, and there will be a bumpy ride because of a lot of issues like depressions, atrial fibrillations, fish oil, hemorrhagic CBA, statin myalgia. And I have also showed her this slide. All over the world, be it US, be it UK, Netherlands, Germany, Australia, the number of PCI is much more than the number of CABG done. And it's not rocket science to understand from this slide that PCI is more favorable. I also showed her that the superiority of stent on all sudden death in 1 million of people if you use the state-of-the-art everolimus stent like Giants for your informations. And the reductions of mortality, 25%, which is 5% or above CABG. And there was a time when cardiac surgery was done like this, and it was a hot topic. And now we do angiogram or angioplasty like this way. And I tell you, the surgeon will scare you that stent gets blocked faster than graft in proximal LED in stable ischemic heart disease. And you have to come back to the surgeon for the repeat procedure. So for me, I tell you, my lady, for me, first revascularization, second or repeat revascularization, just like this, just show your hand and I can fix your jaw. Even the surgeon will tell you that they have robotics. I tell you, they just ordered this robotics in their hospital and they're still learning. And they'll also tell you that using robotics by Lima graft, mid graft, etc., your pain will be reduced, your mortality, morbidity will be reduced. But if you go by the law of conservation of pain from robots, pain can neither be created nor destroyed. Minimally invasive cardiac surgery transfers the pain of surgery from the patients to the surgeon. Go and find a surgeon friend who will share his pain with your robots. And how much they will give you? They will give you peanuts. At 8 years of freedom with PCI, you just get 3 months. Are you prepared to incise your chest and sell out your soul to a surgeon by doing surgery? I am sure she will say no. Diminishing mortality gap between PCI and CABG has come down significantly with third generation and fourth generation of stent. And the debate is still going on whether CABG is best, CABG versus best DS, or 100% Lima versus 100% DES. I'm sure all stents are not born equal, but all Lima are not born equal too. All equal Lima are not grafted equally in all proximal LED by all surgeons, in all patients all over the world, all over the time. And if you see the benefit of PCI in proximal LED, my lady, you save money for the nations. You save health workers from the exposure of COVID and blood-related disease, less productivity on the health system, wasted blood for better cause, long bed occupying lesion, dialysis. And your stent is on the shelf. You come anytime, you have a problem, I'll fix it. Lima is an imagination only. And I have one evidence for proximal LAD, whether you're diabetic or non-diabetic, it is as good as 1A in left hand syntax 0 to 21. And they will show you this reference 1994 by Selim Yusuf. This ICE is reference when CABG, BMS, occluded stenotic reflex, etc., was compared with the PCI. I'll tell you, if you read nicely in the newspaper, in the social media, both the surgeon and the cardiologist, perhaps we are in the same boat. Now we are confronting which one is better. Maybe the surgeon may not agree with me. He may not be in the same boat. He may be in a light boat. I'm in a speedy boat. But we are having the same, feeling the same storm, whether we exist or do not exist, the revascularations. Since my topic is on PCI, I'll talk on PCI. Look, in this ischemia trial, proximal LD is not a majority. That means in 54% cases, there is a non-proximal LD. How can you expect a death benefit when we're dealing with non-proximal LD? And we are talking about data rich zone. The data rich zone is CCS class 2, 48%. We are also talking about asymptomatic patients. In Orbita, we are talking about 53%. In data rich zone, how many of us do treat this kind of patients? No, I do not treat zero angina or class 1 angina, class 2 angina with a deadly stent. And even in Orbita, you get 10% gain. So that's a pneumatic gain. That is also a gain. But sometimes less is more. You should not look at the p-value. We are also talking about monthly angina and no angina at all. We cardiologists do not treat this stemmed animal which doesn't have angina or a menstrual phenomenon which comes in a month with knife and stent. And look at this beautiful curve. At 2 years, there is no favor, not in favor of stent, rather is harmful because of procedural MI. But once you live for 2 years, the life is more beautiful. You have more event if you do not undergo PCI or revascularations numerically, but p-value is not significant. So how much you lose in first 2 years? 1.7% by increasing procedural MI, spontaneous MI after 2 years, you gain 2.9%. And you go to CKD subgroup, you lose 0.7%, you gain 1.5%. So which one is better? Then if you just enlarge the scale, you get this kind of difference. And if you keep on walking with your stent after a good fixing, with the imaging, with post-dilatations, good DAPT, good static, you will see the benefit in longer term. And today's pain is tomorrow's gain, and it's coming from sealing of the vulnerable plaque, maybe prolonged DAPT once you have a proximal LAD stent, less drug-related issue. Somebody will say, this MI does not come on severe lesion. Who told you? Somebody written in the books 1988, and these people, little all Ambrose, that time there was no imaging, no CT scan. So these are the recent data. The most of these MI, they come on severe lesions. So this is a myth that minor lesion only causes MI and significant lesion does not cause MI. And how much you gain? He was on spontaneous MI. Now you have to look carefully in these trials. I have enlightened these mass, courage, bari, fame, and ischemia. Ischemia is the largest of all. Superiority, 5,000 patient, largest patient. We are talking about 64 years. We're not talking about 40 years or 90 years. We are talking about long follow-up, but in fame, it is just 7 months. We are talking about 0 to class 3 angina, not class 4 angina. Even in ischemia, it is class 3 angina and 0 angina. There is no angina. We are talking about people who are relatively low-risk people, ejection fraction 60%. We are talking about angiographic selection. For the first time, it is CT angiogram. In the rest of any trial, it was based on angiography. So there is always a human factor there. So occluded stenotic reflex did play a role, and we are penalized for that. So mandatory ischemia, primary, etc., there. And there are two types of ischemia, fame, and 5 types of ischemia. A lot of patients are excluded. And in fame trial, 1/3 of patients had FFR normal. And do you have better revascularization technique? And Orbiter trial, like there is something called reverse placebo. A man who has walked for 8 minutes in Orbiter trial, how can you expect to run another 8 minutes after going through the sham control? It's not possible to run 18 minutes. So you're not going to get benefit if somebody has already run 8 minutes. So these are called reverse placebo. And this man is scared because he knows, he doesn't know whether he has got a stent or doesn't have a stent. And ischemia trial, again, has opened up a new chapter, but I tell you, these are non-proximal LED which dominates. And look at the crossover rate, 28%, 80% in Orbiter, 51%, and they know that stent is better, and they have ran away from this trial. And there is a lot of critics that 64% is the diameter stenosis. We do not treat 64% or 50% or CT angio. So it's ridiculous to include patient at 50%. Angina ischemia is an important indicator of death spontaneous MI. Knowledge of ischemia trial should be used intelligently, not as a standalone evidence. We have in 1977, BMS, radial P2Y2 inhibitors, shared decision, artificial intelligence. We have 1964, venous graft by Carrot, Lima, shockwave, OCT, DS, and robotics. And look at this crossover, 80% in Orbiter, 51% in FAME, 28% in ischemia, 32% in Courage. And look at this angel and demon story. Demons are destined to live in hell and angels in heaven. When the crossover happens, they cannot survive. The problem is the randomization after CT scan, the person who is doing the CT scan, he has seen it. So whatever is seen cannot be unseen. And look at these Orbiter patients. You can find one Indian there. If they are referred to you for pre-anesthetic checkup, for major cardiology clearance, after orbiting 3 months in Orbiter, the PCI group will be given much faster clearance and with much comfort. And FFR, IFR, we have learned from FAME2 trial that it prevents death. And after going through the ordeal, we have to unlearn, or you have unfamed the FAME2 trial, Dr. Lamy, and imaging on battlefield. When you have two eyes, why don't you use? So you are using these things. Now, ladies and gentlemen, I think this PCI CEBG, it's a coordinated, collaborative approach, and everybody is a part of the game, be it cardiologists, be it CT scan, be it imaging specialist specs, or echo or dobutamine. Everybody should be in the field. It should be a hard team or a team approach. Then only we'll be able to succeed, and we'll be able to overcome the complexities of understanding angina and NFA. And these are the patients. First patient in the history, the proximal LED. He had OVA, he had DS, he had another restenosis. The death can never be prevented, I tell you, friends. It can be delayed only. And placebo is also part of medical care. So even in ischemia says it's a placebo effect of the stent or CABG, I will take that. So while first patient is still kicking, maybe he had vulnerable plaque, which Grunzig has sealed in proximal LED, which was physiologically significant. So these are all guesswork. Lifestyle modifications are not good enough. The Ice Age people used to exercise a lot, eat fruits and vegetables, eat raw meat, sleep well. Still, their life expectancy was small. Maybe we are heading towards the wrong thing from FFR, IFR. So we are barking at the wrong tree. So maybe we have to look, or we have to dig up into newer sciences, better sciences. We can definitely reduce the gap between CABG by newer devices. Nowadays, we do not use the socket stents. We are using laser cuts, much thinner. And there is a pain of today in surgery in Lima, is tomorrow's pain too. They live with mutility. They have problems with CKD, dialysis, frail, COPD, etc., etc. This is the obese patients. They will hardly find Lima sometimes. So can you measure surgeons' good work on the table? If you cannot measure it, it does not exist at all. So you have to go for Lima. And all the time they say the death, death, death. It is a parachute which prevents death. You don't have to go for trial. It's a gospel truth. CABG prevents MI, but you have to look at what altitude the man is jumping and what speed of aircraft. No scar, no mutility, no stroke, no AF. It's a patient choice. Let's share with the patient. We can also do concomitant procedure like Hocum, Tewar, BMB, Miter clip. And look at this. One of these lady had undergone surgery yesterday. So my fair lady, what we want, a surgery or an angioplasty stent. If you go to a surgeon, can I go to a surgeon? Yes, you can go to a surgeon. It's like asking a barber if you need a haircut to a CTB surgeon. He will always say surgery and surgery. So ladies and gentlemen, choosing wisely between PC and CABG, dead do not come back for arguments. The early mortality is very high, but they always can come back for revascularations. So I'll go for PCI. This is surgeon's preference. I favor all kinds of people. Sometimes you have to do things for quality of life. So this is my patient. I'll put this patient on table. I'll fix it. Will IFR, IVAS, etc. It will definitely cause pain relief. Life expectancy, I do not know, but I'm hopeful it will. So I'm not bothered with the mess. So my minor inconvenient cardiovascular event, that is repeat revascularization, quality of life is important. So to end, SIG belongs to whom? These patients belong to whom? Definitely to me, because they feel better, do better with intervention cardiology surgeon. You are invited as a spectator or as a referee at best, sir. Thank you. Over to you.
Thank you, Dr. Hazra. Hello.
Yes, sir.
Am I audible?
Yes, sir. Go ahead. I'm done.
Yes. So therefore, thank you, Dr. Hazra, for a nice presentation.
Kunal is here.
Yes, I'm here.
Yes. So therefore, I mean to say it is not clear whether the proximal LAD lesion is an isolated lesion or whether associated with the multiple vessel disease. So whether associated with diabetes. So many things coming up. And second thing, whether the proximal LAD you have ejection fraction, how much it is. So that is the things to be clear. If it is isolated, should be treated differently. If it is proximal LAD combined with the multiple vessels, is not clear.